I'd like to invite the next speaker, Dr. Florence Coscas, who will talk to us about diagnosis and follow-up of CNV using OCT angiography.
Thanks for inviting me to give this short communication at your first international symposium. I wish to discuss with you about some diagnosis and follow-up CNV with Triton swept-source OCT angiography in clinical routine. My disclosure? As you know, multimodal imaging of type 2 CNV shows leakage on FA, ISSOCT eliminates RAP or VPC, structural OCT-B shows PD and subretinal hyperreflective exudation on his eye section. Topcon OCT-A gives a wonderful hyper signal in few seconds with a good tracking. The OCT-A activity criteria of CNV were described by Professor Coscas in Retina with Heidelberg technology 2 years ago. SADA technology was evaluated with COFT1 last year. The sensitivity and the specificity were excellent, and we found the same parameters with Topcon instrument using the full spectrum algorithm with analyzed ratio. We have lacy well shape, multiple anastomosis and loops, dense branching, peripheral arcade, and hypo-intense perilesional halo on Brooks segmentation. On this other type 2 CNV, we have also dense branching and numerous tiny capillaries with a complete peripheral vascular arcade. Moreover, hemorrhages are detectable on the color picture. Fluid is visible on OCT-B scan and leakage on FA, which are included in the complete version of swept-source OCT angiography. Another case, minimally classic with leakage on FA, plaque at late phase on ICG, and as you can see, it's also possible to observe prominent type 2 CNV and in a deeper segmentation type 1 CNV. OCT angiography allows complete description of the CNV activity and CNV type. Another case in disease, the diagnosis is uncertain between polyps and CNV on FA and OCT-B scan, but OCT angiography gives the diagnosis of CNV. From criteria of activity, we can go to criteria of quiescence with this example. At baseline, we have criteria of activity, C-shape fair, C-fan shape, multiple anastomosis and loops, branching, peripheral arcade, and periregional halo. After injection, we have criteria of quiescence. No well-defined shape, no branching, only large and voluminous mature vessels without anastomosis, without loops, without arcade. We have a dead tree aspect. Triton OCT-A allows a follow-up with post-processing tracker point by point. An example. After a loading dose of anti-VEGF, we observe a persistence of activity with persistence of partial peripheral arcade, and we continue to inject. 4 months later and 6 months later, we observe regression of loops, of branching, of vessel termini. We can adapt the rhythm of injection. In routine practice, we have to respond to this question. Is this treated lesion still active? We can check the criteria. We have well-defined shape, few anastomosis, and partial peripheral arcade. These CNV are still active with 3 out of 5 essential criteria corresponding to fluid persistence on OCT-B scan. But let's look a little closer. In fact, regarding this still active hypersignal, we have on OCT-B scan no colorized flow. It is an inactive lesion. OCT angiography allows a customized follow-up. This initial new multimodal imaging shows hypersignal on OCT-A and hyperflow on OCT-B scan. we can adapt the rhythm of injection with more qualitative information. After a loading dose, we observe dramatic decrease of hypersignal, of hyperflow, and of PED. An injection is needed, and we observe at 2 months. Then, visual acuity is stable. We observe low hypersignal, low PED, but more flow. Treat and extend 2 months is decided. Once again, appearance of metamorphopsia with increase of hypersignal, of PD and hyperflow, we adapt, treat and extend to 6 weeks. 6 weeks later, we have a dead tree aspect with drastic decrease of PD and hyperflow, and treat and extend to 7 weeks is decided. OCT-A can show another evolution, here toward an extensive atrophy. We have mature vessel, but be careful, we have also partial active vessel termini. Or an evolution towards an extensive scarring processes, as this case demonstrates with increase of fibrosis. We know that this active hypersignal on OCT-A corresponds to CNV, but this case doesn't need only injection. A comprehensive multimodal imaging gave diagnosis and specific treatment of sarcoidosis with leakage on FA measured on ICGA. These inflammatory CNV are different from those of AMD at diagnosis. Voluminous hypersignal, less branching, less vessel termini. These CNV are more fibrous, associated to dilated choroidal vessels. Instead, this case does not easily highlight CNV on FA in this form of sarcoidosis. At reverse, OCT-A evidences this CNV although loss of fixation point and opacities. As you know, OCT-A suggests diagnosis of flow and help to follow up, but from which origin? In this example, FA and ISSOCT suggest degenerative streak. Here, we have hyperflow on OCT-A and subretinal fluid on OCT-B scan, but FA and ICGA suggest CSC and background check for steroids. On this picture, we have active CNV hypersignal on OCT-A. The question is, need to treat or not? FA and ICG suggest adult onset vitelliform foveal dystrophy diagnosis without CNV, and we observe for 2 months. And for this case, is it only a hypersignal CNV at the age of an atrophic era? FA and ICGS suggest diagnosis of multifocal choroiditis associated to CNV. After this example of diagnosis, another limit of OCT-A is observed with this last case of base dystrophy. We have staining on FA, no defined network on ICG, homogeneous hyperreflective material in front of broke with atrophic areas and subretinal fluid on OCT-B scan. With swept source OCT-A, you can see the cross helping to distinguish CNV from artifact by focal loss of IPE. Here, the hyperflow signal corresponds to residual CNV. Here, the hyperflow signal corresponds also in inferior to residual CNV. But at temporal size, the hyperflow signal corresponds to choroidal vessels. Choroidal vessels became hyperintense by loss of shield effect of IPE, also at nasal side. So, the game has changed. No dye injection, no side effect. But we have to perform a careful segmentation to identify the presence and the type of hypersignal on OCT-A and to recognize all artifacts and then avoid potential diagnostic pitfalls. In conclusion, OCT-A provides complete description of type and activity of CNV, active versus quiescent versus scar. Triton OCT-A achieves a customized follow-up adapting rhythm of injections. Subsurface angiography is a useful tool in clinical practice, and we are waiting for quantification of flow. Thank you for your attention.